Hello and welcome to today's seminar, Finding a Brighter Future for Childhood Blood Cancers. My name is Rebecca Barber, Major Supporters Manager at the Leukemia Foundation. I will be your host for today. Thank you so much for joining us. It's great to see so many of our valued supporters online and here with us today. As we begin, I'd like to acknowledge the traditional owners of the lands on which we meet today and pay respects to their elders past, present and emerging. So thank you so much again for joining us today. Our future at the Leukemia Foundation is to see, or our vision at the Leukemia Foundation is to see a future where all children not only survive but live well with their blood cancers. And with ongoing investment in research and clinical trials, we can give children access to the latest therapies to give them the best possible chance at beating their blood cancer. Survivorship outcomes in childhood blood cancers have increased significantly over time, but there is still more work to do. And this work is only possible with the help from our caring supporters. And thanks to your generosity, we remain committed to support some of the brightest minds in paediatric research. So today you will hear from some of our leaders who will share their work to help children living with blood cancer and the challenges and insights that they've seen over time. I'd like to introduce our speakers. Today you will hear from Associate Professor Rishi Kotecha, paediatric clinical haematologist and oncologist at the Perth Children's Hospital. He is also the co-head of the Leukemia and Cancer Genetics Laboratory at the Telethon Kids Institute in Perth. He is also a very valued member of the Blood Cancer Task Force, representing the needs of children living with blood cancer, working towards our goal of 0 lives lost to blood cancer by 2035. I'd also like to introduce Nikki and her son Jamie from WA. They will share their story. Jamie was just 2 when he was diagnosed with ALL, an aggressive form of blood cancer. You'll also hear from Dr. Laurence Cheung, Senior Research Fellow at the Leukemia and Cancer Genetics Laboratory at the Telethon Kids Institute, and Dr. Cheung will talk about his current research project, which is funded by the Leukemia Foundation to improve treatment outcomes in childhood leukemia. But before we hear from our guest speakers, I would like to introduce Dr. Peter Diamond, the Leukemia Foundation's Head of Research, who will talk to you a little bit more about our investment in childhood blood cancers. So thanks, Pete, and over to you.
Thanks, Rebecca, and welcome everyone to this session around childhood blood cancers. It's my pleasure to be here with you today, and thank you in advance to all of our fabulous speakers and to all of you who have dialed in. So the Leukemia Foundation has had a really long history around supporting research, and I'm the head of research for the organisation, and we are very active in many spaces of blood cancer, including looking specifically at the specific needs for blood cancer in children. So the Leukemia Foundation has a national research program. It's been going for over 20 years now. In that time, we've invested over $55 million in research, and that has spanned across lots of different types of blood cancer. So looking at leukemia, lymphoma, multiple myeloma, amyloidosis, MPN, MDS, a whole range of blood cancers, but also we're very interested in funding researchers and clinicians at different phases of their career. So from either very early PhD scholarship support through to mid-career researchers, and also looking at senior researchers doing multi-year research projects and potentially clinical trials. So we have funded a majority of the senior hematologists in Australia at some point through their career, and we're very proud to have done that, and we're very happy to continue to do that moving forward. We, like every charity, have had serious constraints due to COVID, and it's meant that we have had significant decreases in fundraising, which has significantly impacted our capacity to be able to support things like research moving forward. So your kind donations for all of those of you who have joined us are the only things that enable us to do what we do in the research space, and not only just in the research space, but also in supporting people living with blood cancer now. So I want to take this opportunity to now introduce our first speaker, which will be Dr. Rishi Kotecha. Rishi is, as Rebecca said, a hematologist. He also has a research laboratory, and he is a very important member of the Blood Cancer Task Force, which has been putting together the National Action Plan for Blood Cancer and looking at things that we can do to improve the outcomes for people living with blood cancer in Australia. And it's wonderful to have Rishi here with us today. So Rishi, if I could just get you to turn your camera on. There he is. Welcome.
Hi, everyone.
So we like to keep things really informal here, so I'm just going to call Dr. Kotecha Rishi from now on. So Rishi, thank you for joining us. Really appreciate your time today. So I guess my first question will be around blood cancers in children. What are the most common blood cancers that potentially occur in children, and what are some of the things that you've seen probably over the last 5 to 10 years that maybe have resulted in some really dramatic improvements in the outcomes for children living with blood cancer?
Yeah, so I mean, acute lymphoblastic leukemia is the most common blood cancer that occurs in children. Yeah, and it's actually the most common childhood cancer. It accounts for pretty much a third of all cases of cancer in children. And fortunately, over the last 60 years, there's been a massive improvement in survival rates for acute lymphoblastic leukemia. So 60 years ago, no patient with ALL survived. And I guess, initially, the initial oncologists who started treating patients with cancer, they started giving small amounts of chemotherapy, saw that it caused a remission, so got rid of the cancer, but inevitably the cancers always used to come back. So since that time, successive clinical trials have built on sort of previous sort of outcomes. And they've increased this sort of amount of chemotherapy that's given to children with cancer. So what we call treatment intensification. And thankfully, that's raised outcomes for standard risk acute lymphoblastic leukemia to over 90% today, which is really phenomenal considering that only 60 years ago, no child with acute lymphoblastic leukemia would survive. But unfortunately, there's still some types of acute lymphoblastic leukemia that have really bad outcomes. So those which have high-risk genetic features within their leukemia cells, unfortunately, still don't do very well. And so the most recent developments that I've seen over my career, especially over the last 10 years, is the advent of a new type of therapy called immunotherapy. So chemotherapy is what we conventionally use to treat leukemia, and immunotherapy is kind of like the new kid on the block. And immunotherapy, there's various types of immunotherapy. They act in different ways. And really that's a new type of therapy that's really just come out, and it's been put into clinical trials, has been shown to be effective, has been shown to work, and has shown to improve survival outcomes.
So there's a couple of things you mentioned there that I want to pick on. First is clinical trials. So we at the Leukemia Foundation sort of talk about the clinical trials and the way that we can get the latest therapies to people. How important are clinical trials in the pediatric blood cancer space?
Yeah, that's a good question, Pete. So in the pediatric blood cancer space, I mean, clinical trials have been the bedrock of our practice. So really, pediatric cancer is rare as a single entity when you're treating it as a single institution. So, for example, in WA, we get 100 new cases of childhood cancer across the board diagnosed per year, and while individually that's very stressful for an individual to go through childhood cancer, it's not enough for us as a single institution to be able to treat these patients on our own. So we operate on an international basis. So we operate with all the hospitals in the US, all the hospitals in Canada, and Australia and New Zealand as a single consortium. And what we do is we treat the patients in the same way here as we would do in New York, in Seattle, in Sydney, in Queensland and New Zealand. And by doing it by treating patients in such a uniform manner, we're able to gather up all the information for all the patients that are treated to work out what is the best treatment for children with leukemia and all other sorts of childhood cancer. And what we do in terms of clinical trials is that we have the standard treatment, which is the treatment that we know works quite well. But often there are lots of new treatments coming out, for example, immunotherapeutic treatments. But when we test these treatments, often they're first tested in preclinical settings, so in the laboratory. And then subsequent to that, they're often tested in adult patients. But we really need to work out as to whether they're actually going to work in children as well. And so what we do is we compare the standard treatment, which is the chemotherapeutic approach, versus the new treatment plus the standard treatment, to see whether it has it results in an improvement in outcomes for these children. And like I said, it's impossible for us as a single institution to do those in trials or investigations, because our numbers, number of patients we have is far too small. And so we work, as I said, as global consortia, and that way we're able to test the new treatment in thousands and thousands of patients to really see whether it has an improvement in outcomes.
Yeah, it's good to know that, we're far away from the rest of the world, physically, geographically, but we're not far away from the rest of the world in terms of what it is that we're providing for patients living with blood cancer. So it's exciting to see that we're part of this global community. So the next thing I wanted to talk to you about is that we hear a lot about genetics and how genetics are important and becoming even more important in determining potentially what treatments we give people with blood cancer. How is that factoring into what's happening in children? And maybe this might be an opportunity to also talk about some of the new therapies like CAR T cell therapy and how that fits into that as well.
Yeah, so genetics is really, really important. So really, I mean, whenever a patient with leukemia comes to see us, I always say to the families, this, the first month is a bit of a jigsaw puzzle in terms of how we're going to treat your child. There are lots of different risk factors that sort of contribute to the treatment that we're going to give. And one of those is the genetic features of the leukemia cell. So it's very important to know that this isn't genetic features that are sort of passed down from mum or dad to the child, but it's the genetic features of the leukemia cell itself. And we test for those genetic features, both by doing tests locally here in Perth, and also by doing more extensive testing by sending the samples to other places which are collaborators of ours. And so that way we're really able to find out what's driving this leukemia. And we know that there are certain genetic features that are more aggressive than others. So if a patient has those genetic features, we know that we have to give more aggressive treatment to help the patient overcome their disease. And so that's all part of something called risk stratification. And if we know that a patient has higher risk in terms of genetic features or any of the other clinical features, often the treatment we give in terms of chemotherapy is intensified. But also we know that we may be able to enroll them on certain clinical trials where immunotherapy is involved. So at the moment, we have several clinical trials which involve immunotherapy. So one of those clinical trials is for patients with standard risk leukemia. And what we're doing in that clinical trial is we're actually trying to test whether an agent called blinatumomab, which is a form of immunotherapy which actually targets the leukemia cells, will have an improvement in terms of outcome compared to conventional chemotherapy. And we're actually adding that to the conventional chemotherapy that's being used. Another trial, which is for higher risk patients, so if you've got more aggressive genetic features, is looking at another agent called inotuzumab in the same way. So we're adding inotuzumab to the chemotherapy backbone to see whether that treatment will improve outcome compared to chemotherapy alone. And you mentioned CAR T cells, Pete. Now that's really, really exciting therapy that's coming to Australia. So there are several centres over east that already have the CAR T cell program up and running. And it's been really, really exciting, actually. There was a huge clinical trial that was published in the New England Journal of Medicine that looked at CAR T-cell therapy for patients with relapsed refractory ALL, and that's pediatric and young adult patients. And they found that the CAR T-cell therapies had an amazing effect in allowing these patients who had relapsed to go into remission. And so we're now able to give our patients in Australia, based on the results of this clinical trial, CAR T-cell therapy in the relapsed refractory setting based upon that evidence. And so now what we're doing is we're obviously looking as a global consortium to see whether we can actually bring CAR T-cell therapies into the upfront setting for those patients that have high-risk disease. So those patients that have very high-risk genetics or other poor risk factors.
Yeah, it's super exciting. It's an incredible technology, and I probably will start showing my age here, but when I used to work in a research laboratory, CAR T-cell therapy was an idea, and you know, it's kind of like science fiction. If only we could do this thing where we could manipulate cells in the laboratory and give them back, and they could identify the cancers and kill them off. And now science fiction has become science fact, and it's really exciting. It's an exciting technology. Rishi, thank you. I'm going to get you to stay with us, and I'm going to invite Nikki to join us. Nikki, if you could, here we go. Hi, Nikki.
Hello, how are you?
Absolutely fabulous. Thank you so much for joining us. I know that you know Rishi.
Yes.
You've met before. Thank you so much for joining us today, and take this opportunity for you to tell us a little bit about your son Jamie's diagnosis and what your journey was like with a child with blood cancer.
Yeah, so Jamie was 2 years old when he was diagnosed with acute lymphoblastic leukemia. And he pretty much was just a very typical little farm boy who ran around the paddock, had his own little sheep, Coco, and yeah, loved playing in the dirt. And then all of a sudden, after a couple of weeks of being sick, we ended up at PCH, and yeah, Jamie fell quite ill, and that's when we were introduced to the wonderful oncology team at PCH.
Incredible team. I know that took care of Jamie really well. So what were some of the challenges that you faced? I know that you live in an area which is in a regional area of Western Australia. You weren't close to a major hospital. What did that mean for you?
Yeah, so basically we live a couple of hours from the Perth Children's Hospital. So Jamie and I had to relocate up to Perth and leave my husband and my daughter behind. My daughter had to go and live with my parents, and my husband still had to work. So we had a very split family for just over 12 months, which was extremely hard. But one of the things that made it really easy was the Leukemia Foundation, who provided accommodation up in Perth for Jamie and I for that 12 months, which it would have been impossible for us to juggle financially and the stress of it all if it wasn't for that.
Yeah, I mean, obviously the diagnosis of childhood blood cancer is very stressful for everyone in the family. Rishi, we can see here Jamie was quite young when he was diagnosed with blood cancer. Is that common for children so young to be diagnosed with blood cancer, or is it something that potentially maybe when they get a little bit older?
No, unfortunately, it's very common. I mean, the commonest time is between 1 to 9 years of age, unfortunately. I mean, it's very rare for children under 1 to be diagnosed with blood cancer. But really, I mean, we get a wide spectrum of children and young adults or adolescents as well. So anywhere between 1 to 18, you know, we get patients anywhere between those ages, and you know, there's still a spectrum of patients who get diagnosed between 18 to 30 years of age as well. But then as you get older, it's much rarer to be diagnosed with acute lymphoblastic leukemia, and then there's another type of leukemia called acute myeloid leukemia that becomes more common with age.
So Nikki, what are the types of treatments that Jamie had to go through, and how did he handle them? We see these incredible photos that are on the screen now of him looking
Yeah.
wonderful and happy and just doing great. But how did that go?
Yeah, so the middle photos after all three photos are just before he was diagnosed. So as you can see, it's very aggressive, and it like the photo on the right, he was only, I think that was 2 weeks prior to diagnosis. And he basically, within 2 days of being at the hospital, you whisked into the surgery and having Jamie having a lumbar puncture with bone marrow aspirate and bone marrow trophine, intrathecal chemo, which is chemo into the spine, and a lot of tests and a lot of poking and prodding, and it's quite a grueling experience for a child to go through, and also for a parent to watch your child go through. You know,
Yeah.
to do the fix, it's quite a stressful thing as a parent to watch your little baby be so sick, and yeah, it's quite harsh.
So how is Jamie now?
He's going pretty good. He's currently running around the house somewhere, playing with his toys. But yeah, Jamie's going fairly well at the moment. We've only got, I think, September next year is when our treatment finishes.
Right.
But we still have monthly visits up to the hospital, and every 3 months he still has to undergo lumbar puncture and intrathecal chemo. But through all of that, he's had some pretty down days, but the good days outweigh the down days. Yeah.
Well, it's wonderful to hear that. Rishi, how long does blood cancer treatment generally last for kids with blood cancer?
Yeah, so for acute lymphoblastic leukemia, unfortunately, it's quite a long time. So on average, it's about 3 years, the full length of treatment. And the first 6 to 9 months are very intensive sort of phases of treatment, where patients are often in and out of hospital. They have to live within the Perth metropolitan region. And that's the toughest part, really. After that, they go into a treatment called maintenance, which is what Jamie's in this point in time. And that's generally the sort of easier part where patients can often return home. But acute myeloid leukemia, the treatment is very, very intense. And patients have to pretty much be hospitalized for the whole of their treatment. And that lasts 6 to 9 months.
Well, hello, Jamie.
Hi, Jamie.
Say hello to everybody.
It's great to see him on screen and great to see him so active. So Rishi, Nikki brought up a really interesting topic there, which was side effects that children potentially experience, not just straight after treatment, but long-term as well. So what are some of the things that are associated with these treatments, and can any of them be prevented in any way?
Yeah, again, that's a very topical and great question, Pete. So as I mentioned earlier, the survival rates are really, really improving over the years. And even though we're not getting great survival rates for the high-risk diseases, and that's something we're really working on to try and improve. The other side of research and clinical trials is really to try and prevent the long-term complications of therapy. Now that we're getting so many patients who are doing so well, we're realizing that some of the treatments we give can actually cause complications and side effects. So as part of clinical trials and as part of ours and other research laboratories, we're really working on strategies to try and prevent these side effects. So one of the most common side effects, I mean, it still doesn't occur regularly, but say in 5 to 10% of patients, one of the side effects that can occur with ALL therapy is something called osteonecrosis. Now, this traditionally happens more in older children, so those who are teenagers and going through their growth spurts. And what this is that this is where we have damage to the bones, often the hips and the knees and the ankles, as a result of steroid therapy and some of the other drugs. And unfortunately, this can be quite a debilitating consequence. Often children have to have, they have a lot of pain, they have difficulty in walking, and often in older life, they have to have joint replacements at an early age. So this is something that it's always been a passion of mine to try and look at strategies to first see whether we can treat osteonecrosis once it's happened, but more importantly, is there any way of preventing this from occurring? And so our laboratory at the moment has got a PhD student who's actually working to generate models of osteonecrosis and to look and see whether there's any treatments we can give that might help prevent this complication. Now, that's just one of the complications. There are several others, that are being studied throughout the world. Another one is, can we try and protect children's hearts, because some of the medicines we give can have consequences on their hearts. Not in all patients, but a small minority may have complications in relation to their heart when they've been given certain doses of drugs. And another thing we're looking at is why do some children get complications as adults and why do others not? And so is there anything that within that child or a group of children that we can discover that might predispose them to getting these toxicities? And so that's something we're looking at on a global scale, because again, we need lots and lots of patients, lots of numbers to see why this might be occurring in some patients versus not in others.
Thank you. Thanks for that, Rishi. So Nikki, my final question to you before we let you go is, clearly blood cancer has a very emotional toll, not only for Jamie, but also for the rest of your family. How Jamie has a brother.
Yes, he's got a brother, Riley. He's also got two sisters, Jess and Brianna. And yeah, it's taken its toll on them as well. There was we were also thrown in with a worldwide pandemic, not just cancer. So when we went into severe lockdown, that was quite a scary time for everybody. But I know our little cancer world was petrified. And it limited things like visits to hospital and siblings to be able to see each other. My husband couldn't come up for 2 months because of COVID as well. So it really did impact mentally and emotionally on our whole entire family dynamic. Yeah, definitely.
Yeah, well, I'm so glad to see Jamie doing so well, and going to use this point, as Rishi just mentioned, research is incredibly important for moving treatments forward. I'm about to introduce Laurence, who is a researcher working on a Leukemia Foundation funded research program. Hi, Laurence.
Hi, Pete.
Rishi, thank you very much. Nikki, thank you very much for sharing your story with us as well. And I'll use that as a segue through to Laurence to tell us about research and how that's so incredibly important. Clearly, it's very close to my heart as head of research and as someone who worked in a research laboratory for many years. So Laurence, tell us about the work that you're doing and how it is affecting the lives of children living with blood cancer.
Yeah, thanks, Pete. Well, first of all, I would like to thank Leukemia Foundation supporting my research project, enable research in this challenging climate. So thankfully, my project is funded by Leukemia Foundation last year. And my project is really focusing on the other side of leukemia, basically not focusing on the leukemia cells, but focus on the neighborhood of the leukemia cells. So what we learned in the last 30 or 40 years is leukemia cells don't just work with each other. They like to find partners in crime. So they like to, talk to other cells that around the leukemia cells or around other cancer cells. So for leukemia leukemia cells reside in the bone marrow. So in the bone marrow, there are lots of cells, including the blood cells, the immune cells, and also the bone cells. So what we want to find out is, whether we can understand how the leukemia cells talk to each others. Talk to other cells in the bone marrow neighborhood, or we call that the bone marrow microenvironment. And if we understand the biology or the pathology of this, can we use treatment to interfere the crosstalk and therefore improve outcome of children with high-risk leukemia.
So is that something that's only seen in children with high-risk leukemia, or is it something that's generally seen across all leukemias?
Yeah, it's actually common in children with leukemia. So the clinical study have report that over, I think 35% of children suffer from bone loss at diagnosis. So so that suggesting that the leukemia cells actually impacting on the bone cells. So in this project, we are interested in finding out, what's happening to the bone cells, what do the leukemia cells to do on the bone cells, and can we really use treatment to restore the bone during leukemia development, and whether this treatment can improve survival in children with leukemia.
Right. So, it's bone loss. Rishi talked about osteonecrosis before as well as one of the side effects. So, so you're saying that potentially if there is bone loss associated with blood cancer, that can be restored, or is it that once that bone loss has happened, it's very difficult to get back and we're sort of trying to prevent it from happening in the first place?
It can be restored. Basically, we in our laboratory, the last 3 or 4 years, we are looking at an agent that used in adult with osteoporosis, and we put it into our preclinical model, and we find that we can actually restore the bone during the leukemia development. And what's more exciting is that, once we restore the bone, we also see that the treatment can slow down the growth of the leukemia cells in the bone.
That's really interesting, isn't it? That interdynamic discussion between all those cells in there, not only is it helping restore the bone function, but potentially helping affect the blood cancer itself. It's a very exciting development. How has your research gone? And I know that Nikki told us before about how COVID was really difficult for her, and it meant that things got difficult. What did COVID mean for you in terms of your capacity to be able to do research in the lab?
Well, I think we changed our way of doing research, and we have the new norm now. We are conducting virtual conference, virtual meeting. In terms of lab work, fortunately, we are in Western Australia. We still can carry on with our lab work. So really, COVID doesn't really stop what we are doing. We just need to change the format of, achieving the same outcome.
So before we came on air, we were talking about funding of research in Australia. We've seen the government putting a lot of money into COVID research, and absolutely deservedly so, because it's a big problem in Australia. How is funding how do you see the funding situation for researchers in Australia at the moment?
This is a good question. I guess, from looking at the statistics, so the success rates of getting funding is not great. It's worse in Western Australia. So for national, at the national level, it's very competitive. I think it's very fortunate to have charity like Leukemia Foundation supporting blood cancer research.
Yeah, thank you, and we are very proud to fund research, and your research in specifically as well. And I know, in particular, for early career researchers, and I'm still going to consider you as a young early career researcher, how important is it to be able to get this type of funding?
It's very important. As I mentioned, it's a very competitive field, and so as soon as you finish your PhD, you start counting your time as an early career researcher. Obviously, the experience we have is much less compared to those experienced researchers, and we try to establish ourselves, establish our own laboratory so that we can do our own research, being independent and putting our ideas together. So I think supporting new generation of researchers is very important. So like now I'm funded with Leukemia Foundation. At the same time, I supervise PhD students, start fostering the next generation of researcher. I think this is ongoing and continuing process is very important for research to be successful in Australia.
We completely agree with you, and that is why we're very keen and continue to focus on funding researchers at all stages of their career. And so, as I said, we're very proud to fund your research. So my final question to you is, so your current research program goes for a couple of years. Where do you hope that at the end of that you'll be, and what do you hope to have achieved? And then where do you see the next steps after that in terms of this research?
Yeah, I think research, we got to acknowledge that research is a slow process. It comes into different stages. So at my stage, we are looking at the basic science, understand the disease development, and trying to testing new therapy at in preclinical model. So I hope we'll be able to move that from bench to bedside in the next few years. When we consolidate the data, prove that the agent is effective and is safe to do so in the preclinical setting, then we can move it to, perhaps starting a phase 1 study at the Perth Children's Hospital or other children's hospital in Australia.
Yeah, wonderful. Well, I wish you all the success with your research project, and I completely understand research does take time and it can be painfully slow, and we thank you for your dedication and hard work at trying to come up with new and exciting treatments for children living with blood cancer. So thank you very much. I want to take this opportunity to thank Rishi, Nikki and Laurence for their time today and talking to us about research. For those of you who are on the call, it is an opportunity for you now to ask any questions that you want. As Rebecca said, please do so using the chat function. And I'm going to pass back to Beck to do the Q&A session.
Thank you so much, Pete, and to all of our speakers. I think you will agree, hearing from Laurence and Rishi today, how far we've come, and really how important continued investment in research is to be able to give children the best chance at beating their blood cancer. Nikki, thank you so much for being here today to share Jamie's story. It was great to see Jamie as well. And I know I can talk on behalf of all of the Leukemia Foundation that we are so proud to be able to help with the generous support from our supporters. And that it really is a privilege to be part of such a deeply challenging and personal time in your lives. So thank you so much again for being here today and sharing your story. So we're going to open the Q&A session now. So please do keep sending any questions through that you may have. The first one here, I think, Rishi, this one might be for you. With your knowledge of paediatric research and the increase in survivorship over the years, where do you see outcomes in, say, the next 10 years' time?
So, like I said, in 10 years, I mean, the last 10 years, we made amazing progress. So, with the advent of all these new therapies that are coming through. So, I mean, what I'm hoping in the next 10 years is that we will improve the survival outcomes even further. So, especially for those patients that aren't doing so well. So, in terms of those high-risk genetic diseases, I envisage that we're going to have more targeted therapies that are specifically able to treat those high-risk patients with those specific genetic abnormalities. And I think that will improve the outcomes for those patients who, say, have less than 50% survival rates, to elevate them to the sort of 90% survival rates that most standard risk patients with leukemia are achieving. And because we've recognized the importance of survivorship and that a lot of our patients now are getting into adulthood and leading great happy lives, but that may have some long-term complications. I think the actual support that's being put into survivorship programs and research regarding survivorship will enable us to look at strategies to treat any long-term complications, but also, most importantly, we want to prevent those long-term complications. So I think we're going to be seeing less and less of these long-term complications as time goes on.
Fantastic, Rishi, thank you. We have a question from Emily. The question is, have you done any research on the long-term side effects of fatigue and a weak immune system of ALL patients?
So not necessarily fatigue, but we have done a lot of research regarding immune recovery post treatment of ALL and also post-transplant. So there's been lots and lots of studies that have measured the immune reconstitution, is what we call it. So we're looking at, I mean, the immune recovery is a very complicated and complex process, and there's many, many cells involved in the immune system. So based on the research that we've done, we know exactly now, after you've been treated for leukemia or had intensive chemotherapy or a stem cell transplant, how long it takes before these cells recover. And we know that from this research that's been done, that there are different cells recover at different time points. So certain cells recover very, very quickly within the space of 4 to 6 weeks, whereas other cells can often take several years to recover. And some of the T cells can be, which are important for fighting viral infections, can often take up to 2 years or more to recover. And that's been really, really important, because another area that I'm very, very interested in terms of research is giving patients immunizations during treatment and after treatment to try and protect them from severe infections that might cause complications, things like influenza, pneumococcal vaccinations. And I've done a lot of research on that. And so that all the research that has been done on restoring immune function is really important to give an indication as to when the best time to vaccinate patients is as well, during treatment and after completing treatment.
Rishi, maybe I could ask another question, and it's a very topical question around, and then you've just brought up vaccinations. We know that currently COVID vaccinations aren't being offered to children. What about children with blood cancer? Yeah, so it's a very important question, Pete, because obviously a lot of our patients are asking about that. So at the moment, the COVID vaccinations are being tested in children. So they're being tested in this sort of 12 to 16 age bracket. And it looks like that these are going to be provide positive results in terms of being safe and feasible to do in normal healthy children. And so obviously the next stage will be to test the COVID vaccination in younger children, which I'm sure will be done towards the end of the year. And following that, once we know that it's safe and feasible to give to healthy children, then we'll be looking at investigating it in children with blood cancer. And again, that's something that we'd be very interested in doing here in Perth, based on the infrastructure we have. Again, it's a question that does come up a lot, but at this point in time, it's not available to children with cancer, just because we don't know the safety of it in this population at this particular point in time. But as always, we need to test it in the healthy population first before we move on to testing it in children with blood cancer.
Fantastic, thank you. We've got a few more questions coming through. So the next one is, are you seeing an increase in childhood leukemia? Who might be best to answer that one?
I mean, I guess I can take this one on again as well. So I guess in terms of incidence rates, we're not actually experiencing an increase in incidence rates. I mean, unfortunately, Australia does have a high incidence of leukemia in general compared to the rest of the world. Now, we're not really sure as to the reason behind why that is, and we also don't know the reasons as to why leukemia occurs, especially in children. We are seeing an increase in numbers, but that's because we are having an increasing population, especially during COVID times. We know that there's a lot of people returning back to Australia, because I mean, why wouldn't you? It's one of the best and safest places to be. But coupled with that, there has been an increasing number just because the population is swelling.
And we've got one more question. Do children get GVHD following a transplant? And is there any research happening in this space?
Yeah, that's another great question as well. So unfortunately, children do get GVHD. And I guess the extent of the GVHD actually depends on the type of transplant you've had. We know that if you have a matched sibling donor transplant, then the risk of getting GVHD is much lower. Whereas if you have an unrelated donor or a haploidentical donor, which is one of the parents having to donate because there's no other suitable donors, then you have a much higher risk of GVHD. And unfortunately, we have had several children who have had acute GVHD, and unfortunately several children who have had severe chronic GVHD. But the field of transplantation is changing so rapidly. Again, I mean, I've been at Perth Children's Hospital or Princess Margaret Hospital before for 18 years. And from the moment I started, the advances that have occurred in transplantation and the ability to reduce the risk of GVHD has changed markedly. So one of the things we can do now is actually we can manipulate the graft, the donor cells. So we can manipulate them before they're given to the patient so that we can reduce the risk of GVHD occurring.
So Rishi, I might just get you to very quickly talk about what GVHD actually is for people on the call who might not know what that is.
Yeah, that's great. So yeah, GVHD stands for graft versus host disease. And so this is where when you have a transplant, you have someone else's cells that are infused into the patient. And unfortunately, in some cases, the immune system of the patient recognizes these cells as foreign cells, and they start to fight the foreign cells that have been infused. And this results in a sort of a hostile immune response by the patient. And this manifests as complications, which can range from being mild, so you can get a skin rash, but unfortunately in some situations it can be very, very severe, where this inflammatory immune response can affect the liver quite significantly. It can affect the gut and cause diarrhea, vomiting, and it can affect, in chronic cases, it can affect the eyes, the joints, the skin, and really cause debilitation in terms of quality of life.
Yeah, can be very traumatic, and it's very difficult. I've seen many instances of graft versus host disease, and it is quite traumatic for the individual potentially to go through. Just as an aside, a research project that the Leukemia Foundation is just starting to fund, which is looking at graft versus host disease specifically in pediatric settings, but looking at the effect of the microbiome. And for those people who don't know what that is all the microorganisms that sit in your gut. And if we can manipulate the microbiome to either prevent or decrease the effects of graft versus host disease. So it's a really interesting and new area that we're looking in, and we're very excited to see what the results are from that research project.
Thanks, Pete. We've got time for maybe one or two more questions. This one is from Deborah. So maybe to Pete or perhaps Rishi, can you tell us if there is still any survival outcome between regional and city patients? And if there is, what are you attributing this to, and what can be done to help reduce it?
Well, maybe I can start off just talking generally about this, and then Rishi, I'll hand over to you for your experience. So as what was seen in the State of the Nation report that was put out by the Leukemia Foundation probably a couple of years ago, there are some disparities between regional and metro and state-to-state variations across the country. This is looking at blood cancers as a whole, not looking at the specifics of what happens to blood cancers for children. But what we identified that there was a 13% disparity across the country, and that was due to potentially not standardized practices across the country. Now, Rishi, I know that in the pediatric space, it's probably slightly different because of the consistency of treatment maybe across the country, but please let us know what your thoughts on that are.
Yeah, no, it's a really, really great question, actually. And I think, you know, the work that was done by the State of the Nation report, and, you know, I've been privileged enough to be involved in as a blood cancer task force member and be part of the State of the Nation and the National Action Plan. You know, it showed that overall there was a discrepancy between rural, regional outcomes compared to metro outcomes. And, you know, that sort of prompted me to think, oh, what the outcomes for the pediatric specific population. And when we had a look, we saw that there wasn't actually much literature on this topic. And so this actually stimulated us to conduct research into this area. So we did a joint sort of research project looking at outcomes in South Australia, Northern Territory and Western Australia. So it was a joint research project with our collaborators over in South Australia, who also treat patients in the Northern Territory. And what we actually found was something very similar, in that patients from regional rural areas in the pediatric setting with leukemia actually do have inferior outcomes to those within the metropolitan area. And this article was published last year in Pediatric Blood and Cancer. And so this actually surprises, because as Pete was saying, we didn't expect there to be differences in outcomes. And so now what we're doing is we're now expanding this into a national study. So we've got New South Wales, Queensland and Victoria on board to increase the number of patients we can analyse to see whether this holds true for the whole of Australia. And then that will give us sort of evidence and armamentarium to look with the National Action Plan and the great work that the Leukemia Foundation have been doing to see how we can make improvements for those patients that are living in regional rural areas.
Fantastic, thank you, Rishi. We might have time for just one more, and I think this one might be for you, Laurence. Can you tell us what has been the most important finding from your research so far, and what specifically you would like to achieve from this particular project?
Yeah, I think in the past 4 or 5 years, our laboratory, you know, as what I discussed, focusing on the research on the bone cells and the leukemia cells, the most significant finding is when we identify the mechanism how the leukemia cells induce bone loss in our preclinical model. So we basically found out that the leukemia cells actually produce a factor, what we call that RANK ligand, and ask the bone-eating cells to eat away the bones. I think this is a very interesting finding and very important mechanism. And subsequently, we find an agent that if we can stop the bone-eating cells eating the bone away, and we see there's an extension of survival, improvement of the survival, and also reduce the progression of the leukemia. So I think this is the most significant finding in this aspect. And again, we hope we'll be able to validate the finding into other preclinical model and be able to bring it from bench to bedside.
Oh, that's wonderful. Thank you, Laurence. Just being mindful of finishing on time. So in closing today's session, so thank you again to our speakers, so Laurence, Rishi, Nikki, and it was great to see little Jamie here today as well. I would like to extend our heartfelt thanks to all who have attended today, and to those supporters who have specifically funded childhood research. Dr. Cheung's research project has been funded by the Leukemia Foundation, so which has only been made possible with your wonderful support. So we thank you very much. I would like to give a special mention to a lady named Florence Betty Brown. So part of Laurence's project was supported through the generosity and foresight of Florence, who included a gift to the Leukemia Foundation in her will. And it was her wish that this gift support research into leukemia. So that brings us to the end of the session today. I hope you found it interesting and insightful. So over the coming days, you will receive an email with a link to view the session. So please contact us if you would like to get involved or have any more questions. We'd love to hear from you. And to close, when you leave the seminar today, a survey will pop up asking for your feedback and to let us know what topics you may like to hear more about in our upcoming seminars. So thanks again so much to everyone for joining us today, and we hope to see you online next time.